Thank you all for joining us tonight for our webinar. My name is Cindy Pankellen. I am the Senior Director of the Physician Services Department at the American Osteopathic Association. Our webinar for this evening is entitled Update on Telemedicine, and this is geared more towards the coders and billers, and we certainly know that in some cases that is the physicians themselves. And these updates are based on the Medicare's April 30th release of the interim rule. Our speaker today is Jill Young, and Jill has been with us before if you've been on any of our telemedicine coding webinars. And she's been gracious enough to agree to come back and provide us with this update. Before I tell you a little bit about Jill, I thought I'd go over some housekeeping rules. First of all, you are all muted. You will remain muted, but if you have any questions, don't hesitate to type them into the Q&A box that you'll find in the bottom of your screen, and we will address those questions at the end of the webinar. If you do have some sort of technical difficulty or something, please type it in the chat box and I'll do what I can to address that. Also want to let you know that this webinar is being recorded, and the recording and the slides will both be available on the AOA's website for you to go back and to listen to or to refer one of your staff or a colleague to. Also want to tell you that those of you that are listening for CME, following the webinar, you're going to need to go back to the AOA online learning platform. In that platform, you'll look for the Update on Telemedicine for Coders and Billers course. And within that course itself is where your post-evaluation is for you to take. Once you take that evaluation, then you can either download the certificate, print it, whatever you would like to do with it. But we will, of course, be reporting your CME to the AOA CME department. I will go over that and provide the address for the AOA online learning at the end of the webinar as well. So let me tell you a little bit about Jill Young. Jill is the principal of Young Medical Consulting, LLC, a company she founded 11 years ago to meet the education and compliance needs of physicians and their staff. She has over 30 years of medical experience working in all areas of the medical practice, including clinical, billing, and rounding with physicians. Her comments and opinions can be seen in several publications and also heard on a variety of audio conferences. Her background gives her a unique style of teaching using real-life examples of coding and billing situations. She hates boring lectures, so be prepared for today's talk to have a mix of humor and a fast-paced style that will keep you engaged and informed. And Jill, I will turn it all over to you.
Thank you very much, and good evening to everybody. As we continue to learn, we have some, oh, we didn't use your slides. I'm so sorry, Cindy.
That's okay.
You should have told me. There we go. As we look at any information that is being released regarding Medicare and telemedicine, make sure to look at the date, because we have some certainly hard dates that we receive some brand new information, some important information. So this lecture is as current as the information that I could find as of yesterday. And so that's the date that we'll work forward with. I wanted to start with good news and make sure that you had heard that there is a payment increase that has occurred for the telephone call code that Medicare is allowing. If we go back to March when they first allowed the code, the payment for these telephone only codes was very low. And for many of our Medicare patients that don't have the technology or don't have the knowledge of technology, our doctors were losing a lot of money trying to care for their patients. And so not only are they going to crosswalk these payments so that the 99441 is the equivalent of a 99212, Medicare is also going to go retroactive, they're telling us, and they will make the payment adjustments for any services billed with these codes back to March 1st. Now, these telephone-only codes are for our physician and our non-physician practitioners, our NPs, PAs, certified nurse specialists, but the other code that are for the non-clinical providers, the 98966 to 68, did not see an increase in payment. And so making sure that you're using the correct set of codes. I know that I have heard and seen where there are some lecturers and also some MACs that are saying that NPs and PAs should be using the 98966 series of codes, but on all of our CMS calls, they're saying no, they should be using the appropriate codes, which are these 99441 codes. So just wanted to, like I said, start off with some good news. Now, as we look at things that you should sort of keep stored in your mind, we have the waiver 1135, which is the first thing that we saw that started to waive a lot of the conditions for telemedicine and started us down the route of where we are today. We know, many of you know what the CARES Act is, and that's another acronym that we hear about. But the two that I work with is the 1744 interim final rule with comment that came out March 30th, and then the 5531 final rule that came out April 30th. And the April 30th is the one that we're looking at to sort of help us define more than ever, in addition to some new definitions for this lecture. Now, we know that Medicare continues, or CMS continues to release information in the form of Q&As. We'll look at that website at the end of the lecture, and they are wonderfully dating their answers so that we can tell if it's a new response or if it's something old. So we're getting good information and getting qualifying information seemingly every day. Now, just to take a step back, prior to COVID, if we were going to talk about doing telemedicine services, the patient was going to be found in a HPSA shortage area. They were probably going to be in a facility or a doctor's office or maybe in a hospital. And then the provider was in their own office at a different site, and they would provide a service. Now, where the patient would charge a facility fee, and the doctor's office would charge a fee, and those two fees together generally added up to what a normal office visit would be. But that split in the payment is something that I want you to be aware of, because when we talk about they waived that originating site so that now the patient can be anywhere. They can be at home, at their daughter's home, they can be in a nursing home. It doesn't matter where the patient is. They want the patients to stay safe. They want the patients to stay where they are. So they have waived that entire originating site concept, and as such are allowing for physicians to bill for services. Who can bill for the services? Well, it's our usual list that we see. Our NPs, PAs, our physicians, our MDDOs, our nurse midwives, clinical nurse specialists. You can see the list. So if we were billing normal telehealth, we would use the place of service that was created a few years ago, O2. And when all of this started, we used the O2, and what we found was we received a reduction in payment because of that anticipation that Medicare had that someone was going to be submitting a facility charge. That's not the case, and so what we had to do was wait till they told us, okay, how do you want us to bill for these services? And what Medicare said was to bill for any of the telehealth services, to bill them from the usual place in which your provider would bill for that service. So for your office visits, if you are a traditional office, then you would be billing with place of service 11. Even though your physician may be at home making telemedicine calls, you still use the usual place of service that would be used if that code was being billed by your physician. Now, if you're doing provider-based billing, you'd be using, I believe it's a 22. So whatever your normal is what Medicare has told us to use for the telehealth services. Now, notice in this bottom right-hand corner, I have that little CMS logo, and that's to remind you that this information is from Medicare. Medicare then says use your normal place of service and then use that modifier 95 to tell us that you're using the synchronous telemedicine service with that real-time interactive audio and video. The modifier GT is a valid modifier and many other insurances use it, but CMS discontinued use of that when they created the place of service 02. And so it's just easier. And so they have requested, if you're doing a telehealth service, to go ahead and bill it with the usual place that you would bill for that code, and then attach this 95 modifier in order to indicate that it was done as a telehealth service. Now, in both of the final rules, we see this definition of interactive telecommunications system, this audio, video, real-time interactive communication that we see. And we have to be sure, because we have some misconceptions out there, because we have some codes that are audio-only codes that are in the telehealth group, telehealth is inherently audio and video. And so we get confused sometimes. So we'll talk about the codes in a minute, and I'll say that one more time. We had a bunch of services added to the telemedicine telehealth list during this public health emergency, the PHE. You're going to see that acronym over and over again. And these were codes in these listed sections of our code book. Now, if you want to know what the current list is, if you were to say, Jill, can you please tell me if this code is a telehealth eligible code, I would tell you to go to the list and look, because that list has been updated and revised. It has the 80 new codes, and as you can see, it gives you a short description that you can look to. Now, if you'll notice on this last page, it even has the G codes. So many of these services, people will ask me, is the annual wellness visit covered? You can see that code, the G0438 is there. But this latest list that was released has another column on it. And I'm going to, I'm sorry, I want to get a little pen or something here. Let's see. Okay, see this right here? Can audio only interaction meet requirements? So we have some, and we mentioned one already, the 99441 series, which is audio only. But notice your annual wellness visit is listed as a code that audio only interaction would meet the requirement for. So there are some codes on the telemedicine list that inherently are audio only, but there are other codes that in this latest release of information that they have indicated they can be done with audio only. And it is all the ones on this page, and there's some others scattered about. So you want to get that list and print it off so that you understand exactly which services you could do with just audio. When we talk about codes in general, I know that for me, I think of E&M services as being office visits and hospital visits. The 99201 to 215 and the 99221, the hospital admit codes and the subsequent care days. But when we look in our CPT book, in that first section, all of these codes on this slide are listed as being in the evaluation and management services section. So just a notation, because when we look at this telephone only code, you'll notice it says that we have some restrictions. It cannot be originating from a related E&M service provided within the previous 7 days. What's an E&M service? Well, the E&M service is any of the codes on this list. And then it can't, nor relating to an E&M service or procedure in the next 24 hours or soonest available appointment. So although we have these telephone calls that are available as a telehealth service, there are restrictions to it. So that means if you see a patient in the office and you're going to contact them by phone, if it's related to that first visit, then it's not going to be a payable service. And the reverse is true. If you talk to them on the phone and then they're going to come in for an appointment regarding that problem, that second visit's not going to be a payable service. But also there's the crossover between the hospital services. I know that we have some physicians in the hospital that for varying reasons are not going into the rooms. They're calling into the rooms to talk to the patient, but they cannot do that on subsequent days because of this 7-day restriction. So I wanted to be sure that we defined what the E&Ms are. And again, go look at your CPT book yourself and you'll see that whole first section of codes are all called evaluation and management codes. So what are the codes that we're dealing with the most? Well, these are the ones. We have our electronic codes, we have our telephone E&M codes, and then we have our audio, video, real-time telecommunication, our office visits, and then all of the other CPT codes on the list. We know these telephone-only codes here that we're talking about. The first set, as we said, are for physicians and our non-physician practitioners. And then our other codes are for our non-clinician billables. And then, of course, we have codes that Medicare has released with their G codes. And so we're not going to talk so much about the codes because those have been around and we're working with them. If we look at what other insurances are doing, this is a document that Blue Cross Blue released from Michigan. And not only does it have all of the codes that they are covering in consideration of telehealth procedure codes, they have color coded them to show how to bill for them, whether you need a particular telehealth place of service, whether you need a modifier or not. And so this is the sheet that they have produced. If we look at Blue Cross Blue Shield of Texas, and these are just random searches, and one of the things that you're going to have to do if you haven't already done is you're going to have to do some research. But the good news is if you go into the search box, whether it's your Google search box or the Bing search box or whatever search engine you use, and you put in the words telemedicine or telehealth and the name of an insurance company, you're going to get information coming up on their website. So you can see for Blue Cross Blue Shield of Texas, down here it says refer to the telemedicine, telehealth services, clinical payment and coding policies. So it tells us where we're going to go. If we look at this information that was updated on April 3rd, notice where the arrow is. It says, please note on a temporary basis in response to COVID, audio-only consultations will be covered. And so for Blue Cross Blue Shield of Texas, they have some unique allowances. And then on the rest of the document, it tells us, okay, what are we supposed to use for place of service? What are we supposed to use for modifiers? This is a list from the Michigan Medicaid website. And right on the website, not only is this their list of telehealth services, it tells you right there what place of service and what modifier to bill with. Michigan Medicaid also released information early on that said all codes on their telemedicine database will be allowed for the service delivery method of audio only. And so for Michigan Medicaid, all codes on their telemedicine list are allowed at audio only. If we go to Aetna, again, a wealth of information. United Health even gives us dates on this opening website, talking about reimbursing claims from March until June. Our Medicare Advantage plans are encouraged to follow Medicare. They do not have to follow Medicare, but what many of them are doing is following their own traditional commercial policies. So what my recommendation for you is, if you haven't already done it, is to make a grid. Now here are two different kinds of grid that you can make. Neither one is complete. They're just there for information purposes only. And what you're going to need to track is several pieces of information. Obviously, modifiers in place of services, what codes are a particular insurance allowing, and then also which codes are they allowing with audio only, And are there any other exceptions? And as you can see, for some insurances, for example, for United Health, we have a United Health commercial policy, we have a Medicaid policy, and a Medicare policy. And you'll also notice that the modifier is different for one of those. And so coming up with a grid of your payers so that you can have that information to work with your physicians in order to maximize the reimbursement for your services, because a telephone call only for a patient that has one insurance is billable with an entirely different code potentially as another one if the insurance is different. So what I recommended when I did this talk to the physicians, and I'm doing the same for you, is let's let the people that know what the rules are make the decisions regarding what codes exactly to use. In other words, have your physicians have a method for them to give you key pieces of information, and then you decide for that insurance what is the most appropriate code to bill. So first of all, we have to talk about the contact. Was the contact made via email? Did it come through a portal? Or was it a patient that had a problem, or a patient that had an appointment and was given the options of a telehealth service? And were there any qualifiers to that? Was it within 7 days of an E&M? And then as the provider replies or is in communication with the patient, what is that methodology? Is it electronic? Is it telephonic? Is it telephone with video? Was there a recommendation for something within that 24-hour period? But this addresses all of those codes that were on that sheet that we talked about early on when we had the 3 kinds of telehealth services. It allows for a gathering of information in order, again, for you who are doing this research to be able to know, okay, what's the most advantageous code? What's the most appropriate code based on the documentation for my provider to use? And then obviously the last question is, what's the insurance? And that's really what drives it all. Now, from a documentation perspective, and I'm still trying to get an answer, I'm working on it, of consent. We need to have consent. The best documentation I've seen so far is that the patient is aware that they may have financial liability for the service, but I want more. You know, how was the contact initiated? And when we look at our providers entering into a conversation with a patient, the methodology of that conversation needs to be documented in the record, plus who's on the call. And then how are we using our coding from a documentation perspective? Do we need to look at time or not? Do we need to look at the new time, as I call it? Or if we have a patient that is involved with a phone call that had been seen within 7 days, but this is an entirely new problem. And so my recommendation is to clearly state that in the record, that, you know, this conversation has nothing to do with the visit that was had with the patient on a particular date. Now, one of the things that we see for our telemedicine office visits only, the 99201 to 99215, and this is only for them, and we're looking forward in some instances. So you really have 4 different kinds of documentation possibilities to determine the level of service. We have our 1995 guidelines, which we're used to, and whether we're using the bullet points or using time counseling coordination of care time, we have those guidelines. And for 1997, we also have both the bullet point methodology and also counseling coordination of care. But one of the things that the first interim final rule gave us was an advance look toward 2021 and looking at guidelines that address only medical decision making when looking at the level of service. And then also in another option, guidelines that use what, again, I call the new time. So here's what you would see if you were using 1995. It's easy to write down, whether we have minimal documentation. Don't forget medical necessity. Regardless of what method we're using, you have to have your medical necessity documented. if we look at using medical decision-making alone for determining the level of service, it tells us in the interim final rule that we need to still do a clinically appropriate history and exam, but that the documentation requirements for that are not part of the coding, determining the code or the level of service. Now, this is a policy revision. It's on an interim basis during the public health emergency. And then just as a little heads up, the table of risk that we're using is the table of risk that we're used to from the 95 and 97 guidelines. That table of risk will change in 2021. The fourth method, the time method or total time of the visit. We're again using time in our 2020 CPT books in determining the level of service. Again, if we're doing a clinically appropriate history and exam, the documentation requirements of that are not included. We're going to be looking at the total time of the visit. Now, I had a lot of questions about total time, and it is the total time spent both face-to-face and non-face-to-face with the patient on that date of service. So from the time your provider opens up the paper chart, opens up the record, is reviewing the patient's information until such time as they are done with their documentation, any of the time that they are dedicated to that particular patient care is included in this time. Now, originally, they referenced some typical times that were not the right ones to reference. And so in the interim final rule that we saw in May, which was the April one, and you'll notice down here, this little May means that's updated information from May. We got that new rule. They finalized that our typical times are supposed to be taken from CPT that we're using now, so from our 2020 CPT book. If you haven't seen this, this is the AMA's advanced copy of what our office visit codes and prolonged care codes are going to look like next year. And the descriptions have changed, but most importantly, and there's the website where you can get this information, but most importantly, when we talk about what's included in the time, this tells us all of this information. And that's where I get the information from that I've included, because people have asked me to say, how do you know you can use this as part of the time in that total time of the visit? Our teaching physicians are being allowed to use that audio video real-time communication technology. And the best way I have to describe this, and I asked this as a question on one of the CMS calls, was, do they have to use the technology to supervise the resident? And they said, as long as they have it. And I said, okay, so you're saying as long as the teaching physician has a smartphone in their pocket, that they can do an audio video communication with the resident, and the resident has one in their pocket. They don't have to use them, they just have to be available. That would count for the level of supervision needed. And they said yes. And they've said that more than one occasion. So not only are they going to be able to provide supervision and direct care furnished by the residents, they can also then pull out the phone and use that to review their services. And that's kind of a big deal. Also, in the final rule that we received in May, they validated that when services are being performed by the resident, that under the primary care exception, that they are allowed to use these codes. They are allowed also to use the 2021 code leveling concept of medical decision making, or that new definition of time when coming up with the level of service for their office visits only. We had seen what they called the Simplified Medical Record Documentation Rule that allowed for these billing professionals to review and verify rather than redocument information that was included in the record. And they have reiterated that this now extends to all members of the medical team. I would exercise caution if your provider is going to be referencing other documentation and reviewing and verifying, which is by signing that they have done so, that they need to indicate where that information is, so that on audit there is a trail for where an auditor would need to go to find that information. They also said that the new interim final rule says any individual who has a separate benefit that allows them to bill for services, they don't have to be a teaching physician, that they also can sign and verify information. So again, we want to be sure we're very careful in showing where that information is found, remembering that, again, we always have to have medical necessity documented. And so making sure that our documentation meets the requirements is not changed at all, but actually becomes a little more difficult in making sure that all of the elements are there. If we talk about what kinds of diagnoses are allowed, telehealth from Medicare's perspective says, we don't care what the patient's diagnosis is. We want the patient to stay where they are. We want them to stay safe. And so whether there's a patient that your doctor is going to call because they have a fever and a cough and they think they may have been exposed to COVID, or if they have an earache, it doesn't matter what the diagnosis is. The telehealth from Medicare's perspective is without regard to any diagnosis. Again, allowing these vulnerable individuals to keep them safe. Now, we still have to have medical necessity for the visit, and I know I've said that many times, but it's super important to maintain that we have that. From a diagnosis perspective, the CDC released a new code. The information regarding this, again, go to your search box and type in CDC and ICD-10, and this is the screen that generally comes up. Not only does it have information regarding the coding before the April 1st release of our COVID-19 code, but it also has guidelines for the use of those codes. So through just the coincidence of time and a lot of people working really hard, they were able to get this U07.1 code for COVID-19 pushed through on a fast track so that it was released on April 1st. It is a code that is a primary code. It's used always in a primary methodology, except for one instance in pregnancy. And then we're going to use an additional code to describe other symptoms such as pneumonia or other manifestations. Now, what I've done, and these slides are at the end of the lecture after the, thank you for listening kind of slide, is I have put side by side the information that was released by the CDC. So for example, if you have a patient that comes in with pneumonia confirmed as due to COVID-19, what's the date of service? Which methodology do we use? What codes? And if you're receiving rejects and you don't know why, look at the diagnosis set. If it was before April 1st, the U07.1 didn't exist and we needed to code it in this manner. If it was after April 1st, then in this manner. And there are many scenarios included in those slides. And again, they're at the very, very end of the handouts that will be available on the website tomorrow. There is also specific coding information and direction regarding patients who are asymptomatic and they are being screened with no known exposure. So if I want to get an antibody test and I just want to know, then they're telling us to use this code effective April 1st. Why is that important? Because insurances are paying based on coding rules. Insurances should be paying benefits based on what ICD-10 rules have said to bill for codes. And so making sure you're using the right sequences of codes is important. And that's why I've included them in the lecture, but at the end. Now, regarding supervision, again, I mentioned, and here's the little pocket with a cell phone in it, that the level of supervision that is required, direct supervision when we're talking about our auxiliary staff and also our NPs and PAs, that level of supervision can now be achieved with the possession of a smartphone to allow for the physician to be in touch as needed with either the NPPA or with the auxiliary staff. And there's even some information in the new rule talking about for general supervision, which is a lesser level of supervision, saying that during the public health emergency, they certainly could even provide that supervision via text messaging. And if we go back to that teaching physician, if you think of any type of supervision that is needed regarding teaching physicians, any of it can be done through that audio video real-time telecommunication technology. So if it's required to have an interaction, then they would use their phones. If it's not required, it's just the availability of it. Having those phones in their pockets is all that's needed. In the new rule, they also allowed for pharmacists to fall within the definition of auxiliary personnel and are allowing them to bill for some services as long as they're not normally included in the Medicare Part D benefit and also are within their state scope of practice and law, to allow them to bill for some of the services that they can provide, and again, is during this public health emergency. If we look at normal rules, only physicians are allowed to provide a level of supervision for diagnostic tests. If you're looking at the Medicare fee schedule database way off on the right-hand side, there's a column that says supervision of diagnostic tests, and it has levels that correspond to our direct, personal, and general supervision. Non-physician practitioners have not been allowed to substitute in for that level of supervision, even though I know it happens all the time. But technically, by rule, by law, NPs and PAs cannot provide that level of supervision. Previously, now during COVID, they are allowed. So all of the above may provide the level of supervision needed for a diagnostic test. So for some stress tests where you had to have a provider in the department, the NPPA, et cetera, can now provide that level of supervision. We had our remote physiological monitoring codes that we had just started to get used to. They were new codes in the last year or so. And so these codes allow for care either so many minutes or so many days. As you can see, the first two codes are for a setup, and then for 30 days, the second set are for monitoring for our clinical staff. And those are time-based codes. And then some additional blood pressure monitoring. So if we look at these codes, it's sort of a compilation of all of the waivers that we have in place. So the first is that these are allowed for new and established patients. Many services have had that established patient waived, and we are allowed to use the codes for new patients. Consent, if it's required, obtained at the time of service, can be furnished by auxiliary personnel. They can not only get the consent, but also can document it in the record. The supervision can be met virtually. We've talked about that on more than one occasion. And then medical devices are defined on the FDA website. The type of device that you would use for this monitoring has to be an approved device. Also, for these physiological monitoring, the waiver came through because they said, you know, sometimes we have people for this monitoring that we don't need 30 days. We don't need 16 days. We need less than that. And so during the PHE, they said, okay, it's not less than 2 days, but can be fewer than 16 days, that as long as the other requirements of the billing code are met, then they are allowed to bill for that shortened service. And then also these initiating visits, the required initiating visits have a new meaning as well. Regarding COVID specimen collection, there was no specific code that would allow for physician offices that were doing nothing but doing a specimen collection. And so in the May or April 30th final rule, they said, okay, you're going to use the 99211. You're going to use it for both new and established patients, which seems a little odd because it is an established patient code, but it's for newer established patients when the only service that's being provided is that collection of the specimen. Now we know that typically the 99211 is still an evaluation and management service code, and we would still want to have elements of evaluation and management, but the other night on a call, they did not reiterate that, other than to say that, and I think it's on the next slide, where we have our clinical staff assessing symptoms and collecting a specimen. So if the only thing you're doing is taking that sample, then you are allowed to bill the 99211. There is no better code to use for that. And then it says also cost sharing will be waived when all of the requirements are met. Part of that is going to be making sure that you have the right diagnosis. And that, again, is the information that you'll see at the end of the lecture. There are 2 other codes for specimen collection, but these codes are specific to location. One is for an independent lab and the other is for a hospital outpatient department. So don't use those. Use the 99211. And then the new rule, the interim final rule said it is possible to do both of these codes on the same date of service provider. And so that had been apparently a big question, and they included that in the rule. They also expanded during the public health emergency the availability for those 2 codes to broaden to allow certain other practitioners who would not normally report typical E&M services to go ahead and bill for those services. Sorry, I'm trying to watch my time here. And then probably one of the things, and I'm still trying to get this clarified. There are weekly calls that CMS has, open forum calls on Tuesday nights. If you're looking to have a very specific question answered, go to the website and get the information. But the question of what does initiated by the patient mean? Now, on one of the phone calls, they said, well, they put this in because they didn't want doctors making cold calls to patients to solicit for visits. The other thing they said was that although certain services are indicated as being initiated by the patient, that educating the patients on the availability of options is not trampling on that initiated by the patient. So that if a patient contacted the office because they had a problem and needed care, that would be one thing, but also allowing for a patient that had an appointment to be contacted to be given the options of how they could provide that, how an office could provide that care, would not trample on that initiated by the patient. But then in the frequently asked questions, one of the questions was asked about the 2 G codes, and it put that quote in again, we expect that these services would be initiated by the patient. And then the next line says, this means the patient must consent to the service. I'm very confused as to what initiated by the patient and consent to the service means. How does one validate the other? But that's the information we have at the current time. And so I'm still trying to get a good answer from them to get a clarification. But I would say when the question is asked of me, what does consent mean? I would simply put in there that there's financial liability. And again, I'm looking at the information we have, that the service was initiated by the patient in this manner, and stop there until we have better information in those FAQs that will tell us what consent is exactly needed. I'm at a loss for what to tell you, and I'm not usually at a loss. In the new release of information, they said, okay, if the practitioner has determined that a patient should stay at home, in other words, they have greater susceptibility, their medical condition, it's contraindicated for them to be out in public, then the physician, their indication that the patient needs to stay at home can qualify that patient as a homebound patient. And as such, they then have the opportunity for some services that they might not have otherwise have access to. Also, when we look at home health in the interim final rule from the 1st of May, they are saying that they're going to have these allowed practitioners, which is our NPs, PAs, and certified nurse specialists. They can now certify and establish, and then also revise the plan of care, and also supervise items under home health services. And so that's a big deal. And all of this is being done in order to free up physicians and allow them more time for taking care of patients. Now, I know there are probably just a few of you, but I feel remiss if I don't mention it. When we talk about a provider-based department, that's where you're doing facility billing. The patient gets 2 bills, one from the doctor, one from the facility. We know that for provider-based departments, their clarification and qualification in some instances is determined by their location. Are they within so many feet from the main hospital? During this pandemic emergency, during the public health emergency, some of these departments have had to relocate. And so that means suddenly they are no longer considered on campus. And so there are certainly some exceptions to rules that they normally would be working with in order for them to get payment. Now, I've listened to a lot of questions on those phone calls, those open door form phone calls, specific questions, and I would simply say, look at the frequently asked questions, because what I'm hearing is in certain scenarios, it's best to bill it one way. In other scenarios, it's best to bill it the other way. But at the end of the day, if your department has relocated, even though you may not meet the requirement of what you used to be from a billing perspective, you're allowed to use the same concepts that you always used. Again, even though you've relocated. We had modifiers that were instituted this year for services for our OT assistants and our physical therapy assistants. And in the interim rule for May 1st, we are now going to say that we can have services that a PT or OT has established the maintenance plan, can then delegate services to the PTA and the OTA when clinically appropriate. And again, it's all about providing greater access of care. For hospice services, they've opened up some of the hospice services that they can use telecommunication technology when we have a patient receiving routine home care, and also, again, looking at some other qualifiers for our hospice services. For our federally qualified healthcare centers and rural healthcare centers, and again, just to include it a little bit, there's whole sections on information for you. Again, some of the waivers that are allowed to happen via that telehealth option. And then here's the best reference I can give you. If you go to cms.gov and type in the words current emergencies, you're going to come up to this page that says current emergencies. And as you can see, there's a lot of information. And I think if we continue down, and the nice thing is a lot of it's dated. And that's important because I check it almost every day to see if they've released new information. Now, this is the bottom of the page, and you can see we've got billing and coding guidance with frequently asked questions, med-learn matters, fact sheets, end-stage renal disease, all kinds of information. Now, if we go back up to this get waiver and flexibility part at the top of the page and click on that, then this page pops up and you can see there's information specific to physicians. And then I think one more, no, I had one more arrow, sorry. It's the teaching physicians here. And notice these were just updated on 5/15. Now, what a lot of these are doing is they have frequently asked question sheets, and what they are doing is, for example, the one for physician and other practitioners, I think it's up to 52 pages, but they're dating the questions. And so when you see, oh, look, they've updated it, I can go through and just look at the date of the question to see what new questions they have added. And so they're doing a really good job of trying to get information out. This is a phenomenal website that has great information in a compiled manner for both Medicare services and other insurances. You can see there's current state laws and policies. Over here we have some coverage guidelines, and if you click on that, you get this that puts the information into, and this is a grid that goes on for quite some time. Again, our federally qualified healthcare centers and rural health clinics, great information for you, showing you side by side with our normal policies where things are for you. And again, if I go back, you can see at the very top of the page, there's the website web address for you. All right, I think we're going to ask Miss Cynthia to come in and we can do some questions.
Okay, attendees, if you have not already typed in your question, please do so now. And we've had a few questions that came in. Are there restrictions of 7 days for interacting with a pharmacist? I'm assuming that's on the 7 days for the previous visits.
Well, I'm not sure if a I'm coming at it two different directions. I'm not sure that is a telephone call with a patient, or whether they are asking if a pharmacist can use that code.
Can you, the physician that sent that in, I see you raising your hand, but can you type in the answer or the answer to the question, and we'll come back to that one?
Yeah, sorry I need a little bit more information.
Okay. And then the next question, how much do you get paid for the codes office visit outpatient?
You get paid this if you bill it correctly, which means you're going to use the place of service you would normally use and use the 95 modifier showing you're doing it via telehealth. You get paid the same amount you would for a 99214 as you would if it was performed in your office. And for any of the other codes, it does not pay any differently being performed via telehealth as long as it's billed properly. Okay.
And then we're waiting for the clarification on if it's the interacting, if the pharmacist, if you're asking if the pharmacist can bill, or if it's that the patient has had interactions with a pharmacist in the previous 7 days. Can you clarify which of those you are asking? Okay, does the 7-day restriction for doctors only or for pharmacists?
Okay, I think what you're asking is for that 989 series of codes for telephone calls. Let me, don't get car sick, close your eyes.
And actually it says here, if patient had the interactions.
All right, if we look at these codes, okay, I think, because the 7-day interaction has to do with these codes here, okay? The first set of codes are for physicians, MDDO, and our non-physician practitioners, our PANP, certified nurse specialists. The second set of codes, which reads exactly the same, those codes also have the 7-day restriction. So if you go to your CPT book and look up that code, this set of codes reads exactly the same, except for the way it identifies the provider, and they all have that 7-day restriction.
And the services that are not covered, that prevent this from being done as if they, is that on the previous slide?
Yep.
Yep.
And those are, any of these services. Those are all E&M services. So if you go and look up that 98966 code, it's going to read just like this, except it doesn't say physician. It still says not originating from a related E&M service provided within the previous 7 days.
Yep. Okay. All right. How realistic is this that we get paid anything? We have to follow all healthcare workers who bill. Oh, I don't understand that.
I don't either. I mean, you're going to get paid. People are getting paid for these services. You know, some of them we weren't billing things right in the beginning when we talked about the place of service 02, but these telephone calls are payable. There are many different listservs and blogs and Facebook billing groups that are creating lists and creating grids as people are willing to share information, like the grid that we saw, this sort of sample grid, in order for you to be able to see and know how you're supposed to be billing for these services. I know that the 7 days is an encumbrance, and I'm not particularly happy about it, but it is the way the code reads, and these are codes that Medicare just started allowing during COVID, and so it's what we got. So just make sure that your providers are very conscious of the fact that if it's unrelated to an E&M service, then say so. Make sure they say so in the record, and you would think the diagnosis would be different if it was not related, and then that way there you could certainly make sure that if you had to appeal it, you've got good documentation to back it up.
Right. Okay, and then what is your gut feeling telling you about these codes being allowed to be paid after the fact?
It's amazing how often I get that question. In the early stages, when they talked about the codes, they would not necessarily make mention of anything. And then with this second final rule, over and over again, you'll see during the public health emergency, during the PHE, as long as the PHE is, you know, in effect. And so as long as the PHE is in effect, the codes are going to be there. Now, I appreciate, and I've said it, you know, the genie's out of the bottle on this, and, you know, grandma staying home and not having to, you know, with much difficulty get in the car and come to the doctor's office. It's been pretty nice, and they're staying safer. And so it will be very interesting to see if there are some limited allowances made. But when you look at the rules, it now says over and over again, especially this rule that came out on April 30th, during the public health emergency, during the time of the public health emergency, or this is a temporary measure. Even the codes added to the physician fee schedule for that list of telemedicine, telehealth codes, it says temporary addition. So I don't see them lasting forever, but the question is, how long does the PHE last?
Right. I know when you were talking about the Medicare wellness visit, I had never thought about them doing that as a telehealth call, but it makes sense. I mean,
right, because that's, I mean, most of that visit can be done by staff, because
right.
An annual wellness visit is really just an inventory and an assessment of your risks and identifying what screening services you should have and under which schedule. And that's something a staff member can do. A plan is developed, the doctor, you know, looks at the plan, and now you walk out the door of a normal visit with the plan in hand, And instead with this, you know, we'll send it to you via the portal or mail it to you or whatever. So yeah, getting that done over the phone sure is a whole lot easier.
Yeah, and I can see it being more of a benefit to the patient, because how many times do those visits, you know, the patient doesn't understand that visit to begin with. So they're waiting to be examined and wondering what's going on and why they're not being examined and stuff. So I definitely can see that as a benefit all around. So hopefully the payers out there decide to keep that going after the fact.
Well, unfortunately, a lot of payers were just getting started with their own 24-hour nurse line, their own, I have a friend whose company just got bought out, and their first line of care is supposed to be, I think it's Target or Walmart that has a PA in a box, like a doc in a box.
Yeah.
And that's where they're told to go for their care.
Wow.
So there's all different models that are out there. And even during the PHE, there are some insurances that are not allowing telehealth, telemedicine, saying we have our own product and we want you to use our docs, our people. So it just kind of depends.
All right. Can you advance the slides to the resources?
I certainly can. I'm sorry, I was doing that. Let's go. You know what? No, if I do that, it'll get weird. Sorry, we're going for a ride again.
Okay.
Oh, there's all of our ICD-10 codes.
Okay.
And there's our resources.
All right. And before we get to the resources, there's one more question. If you are saying the service has to be different than a complaint done 7 days prior, how are you going to get the whole physical billed for if done within 7 days? Let's say if they see a cardiologist, we cannot ask about the heart on a physical exam.
No, let's look at it a different way. It's not that you can't address a body part. You know, it's if I come into the office and I've got an earache, and then I call into the office because, you know, now I've got a sore throat. That doesn't mean he can't ask me how my earache is doing. It's just that it's for a different complaint. It doesn't mean you can't address that body part. It doesn't mean if the patient was seen in the hospital and they've gone home from the hospital and now they're asking for a call because they've got an earache. I mean, it doesn't mean they can't say, well, how have you been since you've been in the hospital? It just means it has to be for something that wasn't what the other visit was within 7 days.
All right. Okay. All right. So this is the physician support line, and we want this to be something that you physicians are aware of. You're not alone out there, and this can be very stressful for a lot of people. So if you are feeling a little overstressed and need someone to talk to, please contact someone at the physician support line. And then moving on, we have our osteopathic.org COVID-19 webpage. This webpage is being updated regularly by our communications team, so feel free to check that should you have any questions about COVID-19 or anything that's going on. And moving on, we have our on-demand webinars. We've been doing an awful lot of them since this whole thing started. So they are all available on this URL on the bottom of the page. And they are free for AOA members and for CME. So feel free to go in there and take a listen. And then we have some upcoming webinars. June 10th, we have updating your partnership, shareholders, and buy-sell agreements. And then June 23rd, the actual title is not correct. The COVID-19 related concerns, ask an attorney, but this will be a panel of attorneys that you will be able to submit questions to ahead of time regarding things that are going on in your practice related to the COVID-19 or the CARES Act or something to that. And then on a yet to be determined date, we will have a webinar coming up on reopening your medical practice. Again, the registration for those will be on the AOA Online Learning. Again, AOA Online Learning, osteopathic.org. That is where you will find your post-evaluation for the CME. You'll go in there. If you have not registered there, you will have to submit your username and password or establish an account to be able to access that post-evaluation. And then should you have questions after this webinar, whether they be for Jill or for the Physician Services Department, don't hesitate to give us a call. This is our direct line, and that is our email address. And I thank you again, Jill, for a great presentation and for sharing your expertise with us at this difficult time. Thank you all for joining us, and that does conclude our webinar.
Good night, everyone.